Welcome to Law and Justice. I'm Jane Mulcahy. This is a special series on the topic of relationships matter. And today I'm joined by Dr. Adam Burley, and I'm really excited about what I'm sure is going to be a really interesting discussion. Hi, Adam. How are you?
Hi, Jane. Good. I'm very well.
Thanks so much for taking the time to talk to me about relationships, Adam. But before we get into it, maybe you can tell me a little bit about yourself and your background, please.
Yeah, sure. My name is Dr. Adam Burley. I'm a consultant clinical psychologist. I'm employed by the psychotherapy department in NHS Lothian, which is a very small department because we sort of run the psychodynamic psychotherapy side of things in NHS Lothian, which isn't massively in vogue just now. So it's not a huge department, but I don't tend to work a huge amount now. I've spent the last 15 years or so working in and around with people and services in and around homelessness. So people are experiencing homelessness and the services who are working with them. And typically that's involved working directly with people, but also doing quite a lot of sort of staff support with mainly third sector staff who do a lot of this sort of work really, and I think do it extremely well. So my job is to be the nerdy psychologist and help support them in the work that they do, a lot of which is around the relationships that they're in as they go about the work that they're doing. So that's my sort of day-to-day sort of stuff. I'm also on the board of Community Justice Scotland, so I'm kind of interested in more sort of, let's say, psychologically informed approaches to treatment of behaviour that gets called criminal or offensive, or however that might be. So yeah, those are my main sort of interests in.
Thanks, Adam, very much. So I came across you, like so many of the people that I really admire these days as thinkers and practitioners, on Twitter, and then was fortunate enough to be part of an ACEs research event in Edinburgh. And so much really of the discussion around ACEs has evolved, I suppose, into looking also at child development, brain development, attachment and safety type issues, especially when we're really tiny and vulnerable. So as a psychologist, can you maybe tell me how important relationship health is, or relational health is, and particularly the quality of our attachment relationship as babies?
I'll certainly give it a bash. I think it's funny when you said that last bit there, what popped into my mind was there's a little video on YouTube. Actually, it's very easy to find. I think if you type in still face experiment, I think it's probably the first one that comes up, and I think it's like 2.5 minutes long or something. And I go back to it a lot, and sometimes when I'm working, the people I'm working with, we find ourselves looking at it as well, and I sometimes feel like the whole of human psychology is in that 2.5 minutes. I think it might be the most important clip available. In that I think it really sort of conveys something about, in the first minutes of it, the interaction between an infant girl and mum, and then the breaking of that where mum becomes very still in her response to the child, basically disconnects from the child, and how distressing and upsetting and confusing that is for the child, and the lengths that they go to, even within 40-50 seconds, to both to try and reconnect and to express their distress, and how that escalates into really quite distressed behavior. And then of course there's the key bit at the end where mum goes, "Oh, it's okay, it's fine." And then the baby's like, "Oh cool, you're back, thank God for that." And you see something of the regulation and the connection again. And in 2.5 minutes, it feels like you have something of the whole shooting match, really. I think relationships are so key, and yet so often forgotten about. And I wonder why. And I think I find myself thinking often it's because of their invisibility. We can't really see them. They're not available to vision in that sort of way. We feel them often. In fact, we feel them very acutely. But I think they're so fundamental that I find myself with analogies like they're the psychological equivalent of breathing, really. You know, most of us have been breathing since we woke up this morning, or in fact, most of us have been breathing since we were born. But we're so good at it and so skilled at it that we almost forget that we're doing it. In fact, usually we do forget that we're doing it. We don't come home from a day at work, another nice day of breathing, well done me. You know, it's something we just sort of do, really, and do it expertly. And we're so expert at it that we can multitask. We can do, even men, we can do other stuff while we're breathing. But if anyone has ever choked or seen anyone choke, you start to realize that breathing is the whole shooting match. It's everything. And without breathing, nothing else matters and nothing else is important. That all life in some ways is subsequent to this invisible process. And I think relationships are a bit like that. They are invisible in that way. And when they're going well, when we can do them well, because we've had all of that nice early relational experience, we don't notice it. We sort of go about our daily business and getting jobs and partners and having children and making all these connections, talking to the checkout person in the supermarket, you know, like it was easy as pie. And we don't come home and say, another day of successful relating to people, well done me, you know, because
what a shame,
because it's so automatic. And I think, but a bit like with the breathing, if relationships choke, if they choke all the time, and in that little video, just in that middle bit, you see what choking might look like, then everything else turns to rubbish. You know, if we have an ailment, and that is, we struggle to forge, maintain human relationships, then we're going to do really, really badly, because at some level, I was going to say just about everything, if everything that we do is relational, you know, and I'll come on to this a bit if we get a chance, but, you know, big institutions like education, healthcare, the justice system are relational at their core. Yes. Even though that's rarely articulated, it's a sort of invisible substrate and bedrock that sits beneath these big institutions, but is rarely described or understood to be a fundamental part of their functioning in some way. So I think, that's a rather long-winded answer to your question. I think the nature and quality of, I don't mind the word attachment. I think it's good. My only concern about it at times is, you know, in terms of the original sort of descriptions, we might narrow ourselves into 4 or 5 different styles of attachment. But I like a sort of broader idea of the nature and quality of the relational experiences that we've had, for which we might remind ourselves we had no choice over.
Yes.
Like, none of us chose our minds at all, even though we labor under a fantasy that perhaps we did. Maybe when I was about 15, I just decided to be me. Well, it doesn't really work like that. It doesn't appear. So the nature and the quality and dynamics of the relationships we have through our sort of formative years, I think, are profoundly important in determining the health, nature, and quality of the rest of our life in all sorts of ways.
When I was doing my PhD, I was putting in a bit on attachment, and then of course I had to do critiques of attachment, including some of the feminist or sociological critiques, so that it's not all just down to moms, because the way we structure the world. Now, as a mom, I know a hell of a lot of it does come back to us and our health and well-being. Do you think some of the time that we just as well maybe don't quite, as a world and as societies and policymakers, get that if we invest in maternal health and well-being and safety, that should probably have knock-on benefits for healthy babies, children, and more safer societies?
Well, I think we'll probably keep coming back to this a bit. I find myself coming back to it a lot when I'm talking around some of the work I do, is this sort of notion of invisibility and intangibility of relational activity. It's quite hard when you can't see something like that. It's very hard it's easy to not become part of the legislature, not something that you plan for or make policies around. So you can do bits and bobs around it, but to really sort of recognize that the quality, the nature of the relationship, maternal relationship, parental relationship, care relationship between an infant and whoever they happen to meet in the world when they come into it, is the fundament. It's the beginning, and it's the blueprint, which is going to go quite a long way to paint a picture of what your ultimate social structures are going to end up looking like. And I think if we could really acknowledge that sort of basic kind of idea, I mean, it's so basic. I think that's one of its other problems. It's not quite technical enough. It's not quite special enough. You know, the idea of, well, we just want to make sure early life and the relationships that go on in early life are really, really good. And that's where we put our money and our resources and all the rest of it. And then we might find a lot of the later problems, you know, whether it's the criminal justice service or the mental health service or the drug and alcohol services, end up becoming depopulated over a 30 to 50 year period. If we could really recognize at some level that this is the most important stage. And it's fascinating, isn't it, for you and I, you know, listening to the news and reading the papers and hearing the governments speak about X, Y, and Z, and how much of it is post-event stuff. Like we talk about policies we're going to do for this and that and all the rest, all of which is post-event, the event being these early years and the relationships that happen within them. But it's not so much that we hear, it's just, it feels disproportionate that we hear less about, you know, in terms of its importance, we hear less about that sort of part of life and what our executives are doing to make sure that those early times are as safe, secure, stable, dependable, trustworthy, healthy as is humanly possible. You know?
And you mentioned there about, you know, your current role sort of taking care of the caregivers in the psychological setting. When I was talking to Dr. Bruce Perry previously about how to talk policy and influence people, we were talking about hunter-gatherer societies a bit, and how through human evolution we had an awful lot more sense of village for a really long time, and, you know, allo parents and people helping with child rearing, which has very much broken down, and we have paid providers for childcare now as well. But in terms, I suppose, of the therapeutic relationship, do people who end up working in, I suppose, mental health services, whether as psychologists or psychiatrists rather, often find themselves dealing with I suppose relational ruptures at some level? Does it often come down to that, or is it more of a case of chemical imbalances in the brain and that type of thing getting in the way of people's functioning, or a combination perhaps?
It's a big question, Jade.
Yeah.
I think there's a question in there. I
think
I think there is a big one. If the question is something around how typically in mental health services do we understand what it is that we're doing, I think there's a big feedback loop here, which is quite hard to describe, which is, as we, perhaps as a consequence of 40 years of neoliberal politics where the individual is key and ailments are understood to largely be within the individual, and they require individual treatment by individuals doing individual therapy with a special name that can be marketed and all the rest of it. Not through any malice particularly, but through just the nature of the environment that we are all, that certainly I was brought up in, and the training programs that we become involved in, that there perhaps is an overemphasis on technique and treatment and to, at times, the deficit of something more fundamental that we might understand. I think we do understand that a fair amount of people coming into the mental health services are coming in because there has been, at best, complications in some of their developmental experiences, and at worst, devastating, horrific, traumatizing experiences. I think at some level we know that, but the system is organized in such a way that I think even when you have very, very good workers, of which there are many, many in mental health services, they may not be in a position to provide the degree of relational support and input that might actually be required. They may not be able to provide the right dosage, if that isn't too crude an analogy, because of their caseload size and because of the predominant idea of the provision of treatment. And I think my observation, such that it is that what then can happen is that we can end up providing treatment to people who can make use of treatment. And sometimes they're not necessarily the people who are suffering the most. I think, for example, as a clinical psychologist, a lot of our treatments are largely clinic-based, one-to-one in a various modality or another. But most of them, again, I think it's a bit invisible, but I think implicit in them is a requirement that the patient, if they're called a patient, or the person seeking help, needs to be able to come along, trust, and connect with a person they've never met before, internalize what that person is suggesting to them, and make use of that stuff. Now, that's possible for quite a lot of people, but not for everybody. And in fact, for some of the most traumatized, that's really the one thing we might understand they can't do, because the relational connections have been so, or relational experiences have been so awful, that the madness would be to come along to a clinic, trust a stranger, go into a room with them, have the door shut behind them, and then become vulnerable in relation to them. And so we might find that some of the people in the greatest psychological need are unable to jump the psychological hurdles required to access the treatments that are undoubtedly maybe of value to them. And I think that's one of the things I'm very interested in, is the idea of, I guess, psychological access. Again, that invisibility.
Yes.
The consequences of the consequences of psychological trauma are historic, they're invisible. We didn't see the trauma, we don't see the accident. And so we kind of sometimes seem to miss the provision for it. And as that feeds back, I think, what you end up with is a service that is being funded and provided for to provide treatments. And one of the consequences of that is, I think, one of the things that the sort of psychodynamics that underpin things like the inverse care law, where we might find ourselves giving treatment to those that can make use of it, and unwittingly perhaps excluding those who might be in the greatest need of it, because they cannot jump the relational hurdles required to come along to a specialist clinic and make use of a specialist technique and therapy. I'm rambling a bit now, but can I just as an example of that, it makes me think of things like trying to come up with very concrete analogies. Like, we think of physical trauma, we think of a road traffic accident where cars have piled into each other and there's bodies lying on the floor, broken hips and severe injuries and maybe head injuries. And the amount of time and money and resources that we put into physical trauma that we can see and that we can fix, that there will be ambulance calls, there will be ICU, there will be theatres, surgeons, there will be post-operative care, there may be brain injury rehabilitation, physios, but there might be thousands and thousands and thousands of pounds of input to one individual for the visible consequences of physical trauma. But when the car crash is childhood trauma, prolonged childhood trauma, and the consequences are the smashing of trust and the ability to connect with other human beings, we don't seem to be able to put in the same sort of resources. And when it comes to things like accessing services, we make provision for the physical consequences, whether that's wheelchair ramps, adapted toilets, car parking spaces, completely ordinary and the way it should be. But I don't see, or it's hard to see, where is the access? Where's the psychological access? Where's the trust access? Where's the access for people whose main ailment and consequence of trauma is that they cannot trust? It'd be crazy to trust. Like, we do not make provision for access for sort of psychological access the way we do for more visible physical consequences of trauma. That really interesting.
they might also accrue a motley ragbag of diagnoses. Isn't that also true, that they may or may not disclose bits of childhood trauma, for example, childhood sexual abuse, and it may or may not be seen as part of their underlying problems. And then certainly if we just medicate their misery, that may also not provide long-term relief. But it's a vicious circle too, if people are unable to form a trusting relationship in a therapeutic space with someone who's minded to try and help them. On this, about the relational dimension of therapy, I've done some training a while back with Bessel van der Kolk after I read his book, and he stated during that training that the therapeutic relationship is the key change agent, but especially where the therapist can help the person with affect regulation. In a clinical mental health setting, is the relationship between the psychologist or the psychiatrist or psychotherapist or whoever is doing the kind of the healing work as well understood and elevated as it should be, do you think, Adam?
The short answer would be no, I don't think it is. But as I say, there is a sort of feedback loop here whereby we tend to provide treatment to people who can come along and make use of therapeutic relationships enough such that they can do things like turn up to sessions and go into a room and sit with somebody. And I suppose some of my work in homelessness has shown me that there's a whole other population who never go anywhere near specialist mental health services. And in fact, once you get to know them and know something of their story, they would be crazy to, like, the madness would be for them to go along and ask for help after the experiences that they've had sort of growing up, really. And again, I work a lot with third sector staff who I think do a lot of the time do very broad spectrum psychotherapy, because they tend to have a greater capacity to stick in with people, to tolerate not turning upness, to tolerate ambivalence, to have an understanding that this might be a population who have really deep and very understandable anxieties and ambivalences about connecting with any human being, particularly a human being who says they're interested in them, or he's going to care about them, or he's going to try and help them in some way. They might be the most dangerous person in the room, really. And they have a way of working with that and sticking with people in a way that I think historically has been understood as, oh, this might be the vehicle that allows this person to then go on and access some specialist therapy. Was actually, in my experience, in a lot of cases, no, that is the therapy. That is the therapy, is the provision of, as Bessel's saying, again, the provision of a containing, regulating, stable, trustworthy relationship over a developmental time period that might allow somebody to internalize something for the first time, a relational structure that feels solid and feels secure and feels something that can be relied upon. And we're right back to that little video again of, what has the early experiences been like, and what is the treatment for people whose early experiences have all been about dysregulation, disconnection, fear, pain, and anxiety in human relationships. I think there's an important distinction to make somewhere between, we talk quite a lot in mental health services about recovery, and recovery, in my mind at least, implies the idea of getting back something that you once had to recover. And I think there is people who certainly I've met in my career who there's nothing that you would want to recover.
Right.
And so the process is much more about discovery than recovery. Like to discover for the first time that there could be a relationship you could rely upon. Now that's a very, very different piece of work. And I don't think we in the mental health services are necessarily set up for that work. But I think, my reading of the evidence is that for those people who never had any trusted object or relationship growing up, they tend to be the ones who experience the worst sorts of health outcomes and perhaps are in greatest need of psychological help. And as I say, I think my experience of third sector staff is they are very good at providing that sort of honest, present, available relationship over time. And sometimes the time periods are long time periods, you know.
Yeah. So the kind of 6 sessions of CBT is going to be of quite limited use, perhaps, to someone with an extensive childhood trauma history and living in homelessness for several years.
And I think I want to be really clear. I think it's very much horses for courses, and I don't mean it as a cheap sort of analogy, but I do think it's once we become interested in someone's relational history, then it might allow us to think about what reasonably do we expect the person to be able to do. And again, going back to our car crash, we would never go up to a car crash site and say to someone with a smashed pelvis, you really need to get up and get to the hospital to get that looked at.
Yeah.
Because we would understand that they can't do that because of the effects of the trauma on their physical being. Yet we often ask people to go into services to get treatment, asking them to do something that the trauma makes impossible. Because what the trauma has done has smashed trust and has smashed the idea that you could rely on, or that anybody is safe, or that any connection is safe, or that going into a room with a stranger and having the door shut behind you is safe. Like,
sure.
And so I think our services do well for people who can make use of them. But often we don't even get to see the people who can't make use of them. And so it's very easy to not know about them because they're not there. But I guess when you work in somewhere like, you know, the longer term parts of homelessness, you see people where, you know, a typical life story is certainly not something I'd ever seen in my mainstream experiences or through my training. It's as I say, it's discovery, because there's people I've worked with for years and years and years and years, and finally, once we've got to a point where they've been able in passing to say something about their history, I find myself thinking, how the hell did you ever come and see me?
Sure.
Ever. Come and have somebody be interested in you. And, you know, I now it makes sense to me why of the 50 appointments that we made in the first 2 years, you only came to 6.
Right. Yeah.
I mean, I'm amazed you any, you know.
Yeah, and lots of services would just strike that person off their kind of caseload, wouldn't they? Because, you know, there's someone more deserving who will actually value the appointment and come when there's,
someone who can make use of it. And I, you know, again, without the risk of being a bit crass about it, you know, there is times where, in terms of thinking, trying to shine a light on these invisible relational elements of consequences of adversity and trauma, that we are asking people to do things that would be like putting a wheelchair clinic at the top of 2 flights of stairs and 3 escalators, and then blaming the person for not turning up. You know, like, you put barriers in place that the person cannot traverse. They're invisible, you know, because they're not visible. You know, we're back to this idea of how might you make provisos for psychological access. And the way I tended to work, you know, or still work with people is it can be something as simple as having that understanding and knowing that it's very unlikely that person's going to rock up and see you. I think they're really going to be extremely wary of you for quite a long time. There's people I've worked with for 4 or 5 years, and I think they maybe trust me a little bit now, a little bit, maybe. Yeah. And they're still really fucking doubtful about it. You know? And why the hell wouldn't they? You know, what reason do they have? You know, what in their experience tells them that it's a good idea to trust anybody, you know, anybody. As I say, let alone someone who says they're going to care for them, you know. Yes,
given that can be where so many of the problems occurred in the first instance by so-called caring people. But on that then, do you believe that it's necessary for people to feel cared for by their therapist, to benefit from whatever the modality on offer is, whether it's talk therapy or a body-based intervention like somatic experiencing, or do they need to get that little bit comfortable with the idea of being cared for? Is that kind of part of the progress?
Again, I would want to caveat this very much with, I really think it's horses for courses. I happen to be interested in a population who tend to get excluded in all sorts of ways, and I've touched on some of the ways in which they are not, I think, maliciously excluded, but are excluded because we don't recognize the sort of psychological components that we require people to have to come along and make use of us. In terms of the care dimension, I think it's the same thing. I think about my own experience of going for analysis, and I'm not sure I needed my analyst necessarily to be a sort of developmental object. And so, like, I wasn't, I had lots of people in my life. It was more to go and think about some of my own experience and who I was. And I felt important that she took me seriously and that took the work seriously. But I don't know that I was going looking for help because I couldn't make any sort of attachments or had no concept of care and of what healthy care looked like. But I do think there are people whose symptomatic presentations are very much a consequence of having little or at times no experience of what healthy, reliable, trustworthy care looks like. And I guess for that particular group of people, then it's fundamentally important that that care is provided. That's the ailment. It's a bit like and at times, and again I think unwittingly, but I don't know, this is my personal opinion, I think in health service, for all sorts of reasons, I don't think they're bad ones, but I think we're quite phobic of our own attachment and care and concepts like love. It's a very taboo word in the health service. Although it's interesting, my partner works in oncology. She's free to love all her pets. Like there's no problem. They're allowed to say that there. But
so in death, it's okay to be loving towards other people.
But I think in mental health, it's more complicated, and I think some of that is because often we're in situations where we have very large caseloads, and the idea here isn't to provide formative, developmentally important relationships for people. It's to treat symptoms and help the person get back to their life in some way. So I think it works quite well for that particular population, but very clearly, and having worked in this area for a long time, it really doesn't work for people who, as I say, I don't like this word, but the main difficulty has been one of an almost complete absence of the sort of healthy breathing type relationships that a lot of us would just sort of take for granted, and as I say, are often a prerequisite to accessing our more technical and higher level therapies. We don't state that, but they are it absolutely requires you to be able to do things like turn up. And if you don't turn up, then we end up at times reenacting, I think, some of the very difficulties that brought people looking for help in the first place, because we do things like exclude them by discharging them and saying, oh, they're time wasting, or this is the fourth time they've asked for an appointment and they didn't turn up, so and in doing so, again, I think very unwittingly can become the next sort of rejecting, uncaring object in the person's life. It's rare that we would sit with someone who's not turned up 3 times and say, I wonder what the not turning upness means. I wonder what it's telling us. I wonder what the communication is here. I wonder if we're getting to learn something about what it's like to be neglected or forgotten about, or to not matter. Or I wonder if we're getting to feel disappointment. I wonder if the not turning upness is actually giving us some insight into this person's relational dilemmas, that they both asked for something and then weren't able to make use of it. What's that about? And to become interested in it. But we don't typically do that. We go, okay, right, it's mystery appointments, discharge.
On to the next one.
The next one. And as I say, then I think unconsciously we start moving towards providing care to those who can make use of care. And so almost by definition, those whose main ailment is a difficulty in the relationship with care itself, are going to do badly, are going to end up excluded, and there isn't a ramp for them to get in.
Yeah, it's so interesting. Is there maybe also a bit of a barrier towards being more demonstrably caring and loving, perhaps because of transference, and because at some level, as you say, people do know there is scope within the power dynamic for inappropriate behaviors, perhaps, or, you know, that the therapist or the psychologist must mind themselves and be aware of what might be interpreted by the person, and the need to, I suppose, mind their own reputation and stuff in that space. Is that something that's a concern, do you think? Or are people taught about that in training?
Well, I think it's very prevalent, you know, an idea. As I say, I think we have a real and phobia might be too strong, but I think it's, I don't know, I can't really talk that sensibly about it. I think all the things that you described are true, I think, but it really comes from what do we think we're providing. Like if we're coming from a position which is we're providing treatment to patients, and even that description is wants to really maintain the otherness, to say, look, we are the doctor, and that's fine. I have no problem with that. I think there's lots and lots of areas where that is absolutely appropriate. You know, whether that's, you know, going to A&E and I'll be the patient, you be the doctor, I smashed my ankle, can you fix something? That's fine. Or I go and see my analyst and I just want to tweak around some of the darker parts of my mind, and they'll be the analyst and I'll be the patient, and that's fine, you know. But I think it's interesting, isn't it? I was talking with a colleague about housing first the other day, and it sort of strikes me that, you know, my own children are being brought up in housing first, you know. They got given a house first and some wraparound care, and we love them and we try and be good enough and we stay, you know, and all the rest of it. And we boundaried and all this kind of stuff. And it makes me think, you know, we do have this treatment model that's running across countries, and you know, multinational, multi-center treatment trial called The Family, and most patients come out of the family doing all right, you know. And we also know that, you know, a lot of, you know, mental health difficulties, for example, and homelessness and criminal justice issues are a consequence of the family going wrong. And yet when it comes to provide a treatment process for the consequences, we're not really allowed to be a family. Like, that's the one thing.
Right. Yeah, that's so interesting.
In fact, we often at times end up
kick them out of the family.
Well, yeah, looking much more like the dysfunctional family that caused the problems in the first place, that we'll see the person once every 2 weeks for 20 minutes to talk about something, and they can't contact us between times, and, you know, all this very sort of, as I say, horses for courses. There's lots of places where that's very appropriate. I think for people where there has been gross, long-standing relational deprivation and disturbance, it can just serve to reenact that over and over and over and over again. And we may not be comfortable with the idea of, you know, providing long-term caring relationships to people who've experienced high levels of deprivation, but that doesn't mean it's not the right treatment. And as I say, I think in my experience, third sector workers tend to do this very, very well with very, very good outcomes. And I think of, you know, people like street soccer and who are really free to just love the people they work with and talk about them in that way. So we're a big family, you know, and we have each other's backs, and we support each other, and you know, it really seems to get into the heart of what the ailment is about. And then I think of that particular population and how they rub up against health services who need to be, I guess, for whether it's just for resource issues more than anything else, need to be more boundaried and more limited and more depriving, really. How that can exacerbate difficulties for this particular group of people rather than help them in some way.
And yet, if you're just thinking about costs, this relational impoverishment that we perpetrate throughout the system has huge cost implications, because people who are in homeless services might be in A&E quite often, you know, or other crisis intervention teams. There is a cost to not providing the relational kind of holding or containing environment to any real meaningful degree, but it's hugely complex for sure. And the fact that it's poorly understood in general, I think doesn't help.
I think that's what I mean, like, going back to the sort of the road traffic accident. Yeah. It's like, you know, but in other areas, we're happy to spend the money. Like, the money, and I'm not arguing against it. That's exactly what I would want to happen to me if I was in an RTA. You know, I'd want the ambulances there, the paramedics there. I'd want a nice operating theatre to put my pelvis back together, and brain injury rehabilitation and all the rest of it, because it's such obvious trauma. And the slow, invisible car crash of childhood mistreatment just doesn't quite, it's just not so visible, you know. And we end up spending, I think at times, huge amounts of money trying to ameliorate some of the symptoms of it, be they physical or psychological symptoms, you know, without sort of acknowledging that one of the main impacts has been the relationship that the person has with care itself, the relationship that the person has with any other human being itself, that something about human connection has become toxic and frightening and anxiety provoking and alarming. And we talk a lot about relationships as another place where we can become regulated and soothed and all. Well, of course, if it's going well. But actually, for a lot of people, relationships are the single most frightening thing you could ever offer. And understandably, a part of them will fight tooth and nail to make sure no connection is made with you, even when a little other part of them is going, don't leave. Like, I'm still in here somewhere, you know. And I think that bit always amazes me. You know, as I say, I've worked with people who later on, I just think, how did you do it?
Yeah, I know what you mean. I mean, obviously not as a practitioner like yourself, but just having met people who tell me a few details about their lives, I'm kind of marveling at their fortitude. That in some ways they're doing as well, despite all manner of symptoms that make their lives difficult. What you were saying there made me think of your article about Moana again, with a woman called Jade, who you've worked with for a period of time. Can you tell me a little bit about how did the article come about, and was it well received by your peers?
Yeah, sure. I could talk about the article for a long time. So you might have to stop me. It was, well, she's an incredible young woman. I think, again, somebody who would very much fit into that sort of description of, you know, having had the privilege of getting to know something about her and the experiences that she has had, to kind of think, well, how did you get, you know, how did you ever come and even say hello, you know? But I think for a long time, we, you know, understandably, it was very difficult for her to say anything about her experiences or what had happened to her. But always had a part of her that seemed to be interested in thinking about things, and one of the things we sort of alighted on was, we talked about music and films, and we sort of it was when sort of lockdown began, and Jade had sort of come up with the idea of, you know, it's interesting, people's experience of lockdown and being separate and sort of disconnected from everything. She goes, I've been in lockdown my whole life. You know, this is my experience, is to be separate, and a part of me can say, I'm used to it, it is what it is, that's just the way it is. But there's always seemed to be a little part of us saying, there's got to be something different to this. There's got to be some kind of way out of this lockdown. And we talked to Moana for, I mean, literally like a long time, like well over a year, so back and forward, as I think as a kind of proxy way of talking about something of her own experience. And she identified a bit with Moana, this person, this young woman trying to leave an island where they're locked down by fear. Like nobody can leave, nobody can go outside the reef because of the terror of what's out there. And I think she could identify with that very strongly, about how locked down she felt, because of the very understandable terror of going out and connecting with the world and with people. But I think could see something in the, it's Disney, but the sort of joy of escape, like of the,
and seeing something new, feeling something new.
Of feeling something new, of doing something new, of managing to liberate yourself from the lockdown of chronic fear about connection and exploring the world and being creative and expressing yourself and thinking. And you know, as someone who'd been told her whole life just to be seen and not heard, you know, just to be invisible, and yet as someone who had so much to say and sees so much in the world. And then the other thing I think she really caught was, well, two things I think really struck me that she came up with. The one was this idea of, I think in the article we wrote it in terms of bricks, but I think the original thing she'd said was, sometimes you have to defend yourself with the very knives that were thrown at you.
That makes a lot of sense to me in relation to offending behavior, actually. Yeah.
And I really was struck by, I still am actually, and I think that then related to the character of Takar, who she had, I think, could identify with as well. And such an important sort of observation of, you don't get a choice in how you build your defenses. You don't get a choice in the relationships that are available to you. And you don't get a choice in building your mind. You don't get a choice in any of this. And here's Takar, who hasn't experienced physical, she's not been in a car crash, but she has experienced psychological trauma. She's had something stolen from her. She's in distress. And she guards against that by being distressing. She's frightening and she's aggressive. And it's very hard to see when someone's throwing fireballs at you that they might be scared.
Yes.
Because they're being so fucking scary. You know? And I think Jade, by her own admission, she won't mind me saying this if she watches it, she knows a part of her can be scary, both to herself and to others, at times when she is most frightened. And the sort of insight that often people who express their distress in distressing ways can get a very raw deal from things like the health service, because they're not evoking sympathy. They're not evoking concern. What they tend to be evoking is the very dynamics that gave rise to the distress in the first place. Like, they're now throwing knives back at you. So now we're telling them, well, you can get out of here if you're going to be throwing knives around. And how hard it is to sort of see past that. And I think we both got a lot from this sort of idea that Moana managed to get past that and could see that there was something inside to come. And I think Jade, I still think, finds that idea very, I can get emotional about it, very difficult to recognize that anybody could see anything else inside past the big fiery monster. There might be another part of her somewhere that has been in lockdown for her whole life, drawing inside her mind, speaking inside her mind, painting pictures in this guy inside her mind, you know, completely locked down. And I think the courage and risk that somebody takes to ever come out from behind their defensive structure when everything in their life up to that point has told them it's a bad idea. Do not.
It might be wretched in here, but it's worse out there.
Yeah, but it has a safety. You know, it's like, you know, it's a safe death, a safe lockdown, because at least in here no one's going to hurt you. But of course, as time passes, you realize, well, yeah, but nobody's ever going to know you or care about you or understand you, or and it's like to lose something of the fundamentals of what it is to be a human being, you know, if that is our capacity to connect and create and express and communicate and attach with other human beings. And I think one of the real consequences of trauma and adversity, when it's really bad, is to shut that off and in essence lose. It's like a bird losing its wings, like you're losing something utterly fundamental. And then, you know, if this person in that safe lockdown wondering why at the age of 22 they feel like shit all the time and have to take industrial levels of drugs just to manage the internal world, you know. Anyway, Jade, if you're watching, we're working on a second paper, but
I can't wait to read it. I loved that Moana article. It was so interesting. And I just also love the fact that you work together in tandem as a team to do it. I think that's, from my perspective, that's very nice and new, really. But what did your contemporaries make of that? Did they kind of go, oh, this is the way forward, or did it make them maybe feel a bit unsafe that this is a bit?
I don't know, actually. I think probably mixed, actually. It did surprise me that I think there's lots of people whose opinion I really value. Thought this is really interesting, and to me, I didn't question it. It felt really, really important to try and, one, because I thought it was really important material, but two, as part of, I suppose, trying to show this, but to show Jade that some of her ideas have value. All of her ideas have value, but that there's only really one way to find that out, and that is to express yourself. Going right back to that 2-minute video. That it's only by putting stuff out into the world and getting something back that we learn anything about ourselves at any point in time. And to be locked down inside ourselves is a sort of psychic death that doesn't allow growth and development, and to find out who we are, really. I think I was a bit surprised at some of the more quizzical reactions and the idea that it would be strange or novel to sort of put out a bit of work with somebody you're working with. I really like that idea, because I think it sort of and the only bit I was uncomfortable with, I really wanted it to be more written by Jade, but I didn't feel that was going to happen at that point in time, and so I agreed to sort of interpret it and write it in a way that might get it published. But it's very much her ideas and her observations. Well, actually, stuff we built together, I think.
An exchange.
A relationship even. And I think it makes you think, that, I don't know, sometimes in this sort of work, I don't know about the terms patience, and it's like we're colleagues, like we were trying to get an understanding of the situation that she was in and why she felt the way that she did, and what we could do about it, and we were just using whatever we could to talk about these things, and Moana and songs and photographs were good mediums to explore things that might be hard just to talk about directly in terms of her experience. But I think Moana was interesting because so much of her life experience felt like it was, for her part, I think she was very, very surprised to kind of hear that people hadn't seen Moana as a kind of story about trauma and recovery.
Right, okay.
What?
So obvious.
That's what it's about, Okay. I mean, I hadn't seen it in that way before,
Well, I remember when you mentioned it to me, and I hadn't seen it at the time, and then I wanted to see it before I read the article, and it's definitely super interesting and a really handy way actually of explaining to people a little bit about trauma and the relational dimension and the ambivalence of care and what feels safe even when it also feels awful. I mean, I think it's very interesting that way. I'm conscious of your time though, Adam, and I really look forward to your next foray with Jade, so get cracking on that. But just to go back to the adverse childhood experiences science in general, what application or what implications does it have for frontline practice and for relational health in general?
Well, lots, I think. I think I'm probably going to end up repeating myself a bit, but I do think it starts really with recognition, I guess. Can we get to a point where we can keep visible something that is intrinsically invisible, that we can keep it in our minds, that relational access, for example, is not open to everybody, is not equal across the board. That when we talk about things like trauma and early adversity and mistreatment and deprivation and neglect, we are talking about things that all happened in relationships, all of them. And they have a profound impact on how that person then develops internally and how they are able to then go off and form and make relationships in the world. That's important, I think, because, as I say, whether we acknowledge it or not, whether it's overtly stated or not, all of our public services, front-facing public services, are relational in nature too. They are fundamentally relational in nature, and often require the person who is seeking access to that service to be able to relate in a way that was determined by the creator of the service. Now, most services, health services, were created by healthy people. And so we made them in our own image. An idea of, well, if I was sick, I would come along and do, if I was feeling distressed, I would do. And we get a little bit institutionally autistic about it, I think, and forget that there might be other minds around, and that some of those minds may not find it easy to pick up a phone to make an appointment, or go through a 5-choice sub-menu system and wait for half an hour to make an appointment with a practice nurse, because they're so deeply ambivalent about their own health and well-being that that's just a hurdle they won't cross. Or that they won't turn up to a building, even if it's a specialist clinic doing tier 4 highly evidence-based psychological therapies, they won't turn up to it, because that would be mad. Frankly, that would be absolutely crazy based on the experiences they've had up to that point. And when they get discharged for not turning up, that reminds them that this is why you don't go along and ask for help, because nobody sticks with you, nobody's interested, and nobody cares. And I think too often in this realm, we use terms like choice as a way of saying, well, the person chose not to turn up. They said they wanted help, and then they chose not to turn up. And we're very good at locating the difficulty into some of the most vulnerable members of society in a way that we would never do with physical. Like if we did put a wheelchair clinic at the top of 3 flights of stairs and people didn't turn up for their appointments, you'd hope we would at least be able to acknowledge that it might have something to do with us and the way we've set up the clinic. But in this area, we don't. Far too often, I think, I noticed that we locate the responsibility in the person seeking care and are blind to an idea, or seem to forget that one of the consequences of the trauma that they have experienced, it wasn't a car crash that you can see in that way, but the consequences of their particular experiences may be as acutely and in the long term more devastating than those that you get in a car crash. Because broken bones, if we're lucky, can heal when we get function back. Trust. Try fixing trust. How long does that take? And what provision do we make for people whose trust has been smashed in a way they had no choice over? They're not choosing to be ambivalent. They're not choosing to be, in two minds about care. They're not choosing to self-neglect. People don't choose to rough sleep or to take shed loads of drugs or to be, aggressive at the reception in that way. I mean, they haven't chosen their experiences that have led to those particular sort of responses. But we're very good at using concepts like choice as in a way to locate the responsibility. And as I say, in a way that you wouldn't go up to crash site and go, you with a broken pelvis, you are just choosing to stay on this road here. The hospital is only 2 miles away. You should get up and make use of it. You're clearly choosing to just stay here and not turn up to the A&E department. Well, that's on you. And yet we do that. So I think it has profound implications for the ways in which we both understand the consequences of things like adversity and trauma and the provision that we make for it, ranging from things like access to the actual nature of the treatment that we provide. I'm always going to caveat that with, of course, it's horses for courses, but where it's very, very clear that somebody may be coming from a position where there is very little relational quality to recover, and that what we might be seeing is somebody who might benefit from discovering trust, or having trust repaired or built even for the first time, then that's a very, very different endeavor, and one that I'm not sure we articulate very well or provide particularly well for.
I don't think it's in all that many strategic goals that I've read in relation to any service at the moment. But final question, Adam, on this, because it's actually to the wider sort of policy and what type of societies do we really want? How do we want to invest our scarce resources? What do you think politicians and policymakers can possibly do to promote safe, healthy relationships in childhood and indeed over the whole lifespan?
Well, it probably goes back to something we touched on before. I think making it visible, it feels really, really key. Like if there was a, if we had a sort of, I think of sort of crappy examples, but like, we do have a society that recognizes smoking ain't good for you. Like we seem to be able to get these messages across in a sort of, a way that makes common sense to people, and they can digest it and take it on board, and they may choose to smoke anyway, but they get it. And yet something of the importance of early life and early relationships as a concept to be broadly understood by a population seems to elude us. We don't seem to be able to really grasp it as a kind of fundamental aspect of, if you are in government, okay, number one on your design sheet is early life.
Yes.
Like, and that's just,
you don't
even need to, like, that's just the absolute given, because we, like, in the same way that, when an ambulance crew turns up at crash site, it's ABC, airways first. Why? Because breathing is literally the most important thing.
Yes.
Okay, well, if we had that for policies, it'd be the same thing. Relationship, early life is your A, So we're turning up into a society as a new government coming in and thinking, how are we going to address the prison population, mental health, general happiness, well-being, blah, 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 blah. Okay, number one, early life. Okay, and we may not see the consequences of it and maybe that's the problem, is that on a cyclical sort of election cycle, a government may not want to put all of its money into something that it's not going to see the consequences of for a long period of time. So I think our job is to keep shining a light on the invisible and keep on keeping on sort of
plugging away.
Plugging away, discussing the site, really trying to articulate in digestible ways why it's important, what the consequences of it are, what the consequences of not paying attention to it are, because in the post-event space, you and I have work in and around the justice system. The amount of damage and cost and time and wasted human opportunity that we do is at times overwhelming to think about, because we didn't think about early years, and we didn't think about poverty and inequality and housing and families feeling safe and families feeling comfortable enough such that they can have energy left over to love their children.
Yeah, I agree with you. It's big ass, but let's keep plugging away. It's all we can do, Adam. It's all we can do. Look, Dr. Adam Burley, thank you so much for sharing your time and your ideas and your important work and the discussion about Moana. I look forward to the next article with Jade. Thank you for writing the first one, Jade and Adam. And this has been Law and Justice with me, Jane Mulcahy, and the series is Relationships Matter. Hopefully we did a nice enough job in talking about relationships today. I think we did. Thanks so much, Adam.
Thank you.